Thank you very much. I'm very honored to be here. Thank you for the invitation. I wanted to talk on the X chromosome, which is the theme of my lab. But Adriana spent 10 minutes to convince me that this was the most important topic on Earth. So I'm trying to describe the current clinical landscape for molecular testing in Quebec. And I agree that this is extremely important because we need to understand how we can translate all the innovations that have been mentioned today, for instance, in lymphoma by Dr. Janssen, to the clinical space. This is my disclosure, no specific conflict of interest with the current theme. And I want to start by describing a bit the different levels of integration we currently have in Quebec in the molecular setting. So this is the Optilab program. The Optilab program was a consolidation of an extremely fragmented lab environment in Quebec with 350 different labs. This has been merged into 12 lab networks with 2 networks on the Montreal Island, one that is the MUHE-centric network, but actually it's a kind of a happy family with all the labs around the McGill University environment, and the other one being the CHUM. We have multi-organizational divisions. So we have a multi-site division of pathology, and what is important today, the division of molecular genetics, which is the clinical space for molecular testing in cancer, division of microbiology, and so on. There is an interesting system of co-leadership at all levels, with systematically a medical leadership and a clinical administrative leadership. Both work together at all levels. There is a medical director working with a clinical administrative director, and each division has a medical chief and a clinical administrative chief. The 2 directors systematically report to the CEO of the server organization, which for us is the MUHE. And this program is directly piloted by the Health Ministry with transfer to Santé Québec, and we don't know yet how it will look like. There are several benefits of this program if we try to summarize what actually is the situation 6 years ago after the start of Optilab 7 years ago. First, we obviously had scale benefits. I mean, the decision process that was very opaque and fragmented in the past is much clearer now with a critical mass to optimize the equipments. We have the co-management, which is an interesting cultural shift in Quebec. Everything is very quality-centric, which is very important when we discuss implementation of new technologies. We need to follow an ISO-based approach, which I have to say is great, and for some places has been a very important cultural driver. And the Optilab actually sustain what we are going to discuss now, which is the Quebec Molecular Diagnostic Network. And it's also facilitated the implementation on a more agile way, new molecular tests. It's still an incomplete initiative. The only actually doctors working in labs, and the real lab specialists are pathologists. All the others have actually what we call the PEM, which is the clinical affiliation to a non-lab environment, which is very different from what you see, for instance, in Europe with real lab specialists. And I believe this is problematic. The procurement is centralized, meaning that at the MUHE network, for instance, we all rely on the MUHE procurement, which is sometimes problematic. We're going to discuss that. The budget is integrated into the server organization. Sometimes there is a bit of a heavy approach, especially for the central programs. And as I mentioned, we don't know yet how it will look like with Santé Québec. Okay, so now I'm going to shift to another level of integration that I think is really important when we want to translate innovation into the clinical space, which is the RQDM for Réseau Québécois de Diagnostic Moléculaire, with 2 arms. One is genetics diseases, so basically Mendelian diseases in kids. And the second one is cancer. So this network is directly piloted by the ministry. It involves by the regulators, so the INES in Quebec, the cancerology, the oncology program that is called the Programme Québécois de Cancérologie. As you may know, there is no cancer agency in Quebec. I think this is probably the only place in the world when there is no cancer agency in a Western country. The CQGC at Saint-Justin's, standing for Centre Québécois de Génomique Clinique, which is mandated to run all the high throughput tests like transcriptome, GeneSeq, exome, and the ministry that is actually the pilot of this group. We have bi-monthly statutory meetings. All the recommendations we made were aligned with the INES. And the overarching principle is that everybody in Quebec should have the same access to sophisticated tests, irrespective of the center of origin, which is, again, different from, for instance, a European approach where you have cancer centers, and these cancer centers are really centers of excellence. In Quebec, it's different. The ministry has always refused to have cancer centers because they thought that this would impair the principle of fair access and even access across the province. So just to summarize what you already did, I believe that we achieved a lot. We developed, standardized, implemented, and got the reimbursement for next-generation sequencing in almost all solid tumors, in hematopathology, and especially the myeloid situation as well, basically all the lymphoproliferative diseases, some situations with lower prevalence like central nervous system, sarcoma, and some situations like the pediatric tumors. We developed a process for high throughput sequencing for the category of adults and adolescents and young adults. Voluntarily, we decided not to define an age. So when there is a phenotypic presentation of a disease that looks like a pediatric tumor, like in a sarcoma, but not only, then actually it's possible to get a reimbursed transcriptome and exome and GeneSeq. All this has been done in tight interaction with the INES. We have an interaction and an overlap with the gene committee. The gene committee is the genetic committee. The genetic committee actually oversees the tumor suppressor genes and the hereditary diseases. So we have already standardized, implemented, and reimbursed low throughput and high throughput next generation sequencing for different situations, like situation associated with HRD genes, Lynch, more rarer situations like Van Hippel-Lindau, P53, the different MENS. This has been done. Okay, so what are the next steps? The next step is obviously to transfer all of that to the same process to liquid biopsy. So there is a working group that has been directly mandated by the cancer committee of the RQDM that I chair. This working group is led by Andreas Papadakis, who is PhD here at the LDI. The first wave was to prioritize for specific indications in lung cancer patients, 3 indications, patient too frail to be biopsied, so kind of therapeutic emergency when we need a diagnosis by 10 days, and situations where we have an unsatisfactory tissue biopsies to avoid resampling these patients. This is the case in 14% in our hands of the patients. The second wave will be for colorectal cancer. We mandated the INES, we have authority to mandate the INES for recommendation. And there is a report on ctDNA that I invite you to read. For those of you who are not familiar with the INES process, I think it's interesting to look at this recommendation that is quite wishy-washy, because the fear of the INES was that people will try to shortcut the pathology process, sometimes the lengthy pathology process, sometimes for very bad reasons, to something that would be more rapid with liquid biopsy, and obviously to replace something that costs $200 with a technology that would cost $1,500. Why we decided to focus on the next wave in colon carcinoma? Because we have extremely solid set of data to show the importance of ctDNA in two situations. The first is to guide perioperative treatment. And again, like in lymphomas as illustrated by Dr. Johnson, to really take a decision on intensification or not. So actually, we know from the Galaxy trials that the ctDNA provides an extremely strong prognostic value, and based on that, it increases the benefit-cost ratio of giving a systemic perioperative treatment stage 3 colorectal carcinoma. We also know for another spheres of clinical trials, the Galaxy trials, that the ctDNA is also associated with a predictive value. Here you may see on the left part of the slide that actually these trials were comparing the standard approach with a ctDNA-led approach. And you may see on this table that actually the patients who were followed by standard approach had much more often received a systemic chemotherapy than the patients followed by ctDNA. And this is the result showing that there is a complete futility, and futility was reached, meaning that there is no survival difference, actually DFS difference, between these two populations, showing that when you use ctDNA, you save money, you save toxicity, and you improve the quality of life for the same result. This is also a paradigm for something that is very important when we try to go to a value-centered approach, which is the importance of have a clinical pertinence-centered value appraisal, meaning that we really need to take the clinical pertinence and to integrate that in the balance of which technology we are going to use, which approach, and this is lacking currently in Quebec. And we really need to sit down all together, meaning clinicians, healthcare providers, researchers, developers, to see how we can define in the specific Quebec environment the right algorithms for this type of technologies. Okay, despite all of that, you can see here in the last data coming from the ministry, this booming in volume, but also in value, number of cancer molecular diagnostic, completely led by the cancer-related molecular diagnostic with a predictive increase of 56% per year for the next 5 years, both in volume and in budget, so in cost, in public money spent to this test. So this is really important. I think we've been successful to offer the population an access to these tests. Nevertheless, we do have challenges, and I'm going rapidly to go through these challenges. The first one, and it's a nightmare, is the middle age we are in Quebec in terms of information system. This information system, 2 minutes, it's a lot. So information system is really super fragmented. We don't have interoperable systems in Quebec. We don't have in 2024, another peculiarity of Quebec, we don't have a molecular genetics system, a laboratory information system to run all these tests, and this is extremely problematic. There is a lot of pressure, I have to say, both sadly and proudly, on both the MUHE and the Jewish General Hospital. Together, we've served 68% of the population with cancer. These are the last data coming from the ministry. The green is cancer. You see that if you add both the MUHE and the Jewish, you have more or less 70% of all the volume of cancer tests done in molecular genetics. We do have severe HR shortage of technologies. We are trying to overcome that. We are going to discuss the procurement aspect with block of new equipment. The community of practice is emerging, and I'm happy to say that I've been asked to lead a molecular genetics community of practice in QCRO. I invite all of you, actually, to be part of this community. It's very simple. Just send me an email and you get it. And the second problem is that the population is not very engaged in all these aspects we've been discussing today in molecular genetics, as opposed, for instance, with the UK, where there is one single day that there is not a large op-ed in the media on explaining the importance of genetic testing, what is molecular testing, what is ctDNA, etc. And I believe that this is very problematic. I'm going to skip all of that to say that nevertheless, we've been assessed by a think tank in Ottawa, led by Don Usro. We've been ranked second in the country after Alberta, with several challenges that were rightfully identified, especially the poor involvement of the population. I just now, before concluding, to pay tribute to someone who I really believe is a kind of hero in this field. And he's Leroy Hood. We've been privileged with Jerry Baddest to discuss with him and meet him very often in the international consortium called the Worldwide Innovative Network. Lee Hood has been at the origin of most of the discoveries in technology in the 20th century. For instance, automatized sequencing, automatized nanostring platform. And he was at the origin of two very important thoughts that I would like to share with you. The first is the idea of dense correlation networks. In a nutshell, this is the idea that you need a smaller population of individuals if you get much more data points that you will be using to profile these people. And this has been working very nicely even before the AI, but you can imagine how with the AI, this is obviously changing the world. The second thing, the second idea I'd like to share with you is this very important virtuous circle where you have this permanent crosstalk between biology, technology, and computation that is generating each time new hypotheses and new data that will enrich actually this circle. And the question we are having now in Quebec is how do we reinforce and transition what I think should be called the Hood's virtuous circle into the clinical space when the clinical information system is completely broken? And the only answer is with partnerships. So I think that it's time now to put in place agile and smart partnerships with the biomarkers industry, with the pharma industry, with the computation industry, to precisely palliate the absence of a strong information system. So if you agree, I can conclude rapidly with several points. The first is that despite the usual resistance, the Optilab I think, has been quite successful despite challenges. RQDM is clearly a success in terms of implementation of this test. We have major challenges, many related to the information system, as I mentioned. We need to invent a smart, innovative procurement system. Our procurement system, meaning the way we get supplies, especially innovative supplies in our hospitals, is completely broke. And we need to reinvent that. I believe Santé Québec will offer an opportunity. I don't believe that it can be worse, so it can only be better. And we need to fuel the AI projects with a strong data management system. This has been a recommendation of the Chantier Transition to Santé Québec, and I think it was a very interesting exercise to try to strategize the transition to Santé Québec. And finally, as I mentioned, we need to build a dynamic culture of partnerships, and this is still to be created. Thank you very much.